Okay, well, thank you all for joining for the webinar tonight, and thank you to John and Sarah and everybody else with the Curable team for giving me permission to come and do a presentation for you guys. And what we're going to be talking about is why we hurt and what to do about it. And I really consider this information really to be the first step to mastering pain. Now, I'm going to go into my background, who I am, and who should be listening to me, or why you would even bother listening to me in just a second here. But I want to give you some ideas about what the goals I have with this particular webinar, and one of the reasons I wanted to present this to the Curable community. And one of the first reasons is I do a lot of pain education. I do a lot of talks. I did a lot of work in my own local community. And I've given this talk to a lot of different audiences. But this is the first time I've ever had a chance to put it into an audience, such a large audience of people who've either experienced persistent pain or experienced the symptoms associated with persistent pain. And so I am looking forward to your feedback to see how this presentation helps you, what makes sense, what doesn't, and also to kind of to extinguish some myths and misconceptions when it comes to pain, which are pretty prevalent even in kind of modern communities like Curable, which is doing a fantastic job. So my goals for this particular presentation, number one, is to challenge some beliefs. One of the interesting things I found about pain is there's such a tight relationship to what do we believe to be true about pain, and sometimes those beliefs can get in the way. And I am not here to disconfirm or invalidate or take away from anybody's belief systems, but what I do want to warn you about is our beliefs, which tend to guide our behavior, also defend themselves when they feel that they're under threat. And one of the ways that you'll recognize this is if I say something and you get this visceral reaction, your heart rate starts going up, your stomach starts kind of going binding into knots, and you want to say something like, "Dr. Cuccaro, you are an absolute idiot." That's okay. What that means is we're touching some beliefs, and that's what beliefs do when they're under threat. But instead of saying, "Dr. Cuccaro, you're a complete and utter idiot," what I would like you to try to do is put a question mark at the end. So, "Dr. Cuccaro, are you a complete and utter idiot?" Question mark. Because what that question mark allows us to do is have a discussion. It means that we're willing to have a little dialogue, and then we can learn from each other. And that really is kind of the first step in this process. The second thing is to promote pain awareness. Now, I know this particular community talks a lot about pain, which is one of the exciting things about it. But I want to talk specifically about the science of pain. And again, I'm going to present it in a little bit different way, in such a way that I'm also hoping that you guys come away with this feeling empowered and feeling like you can talk to other members of your friends and family and describe pain in a way that helps to make sense of it for them. And that, I think, is particularly important, is because with the dialogue around pain, we often talk about treatments, what works, what doesn't, but we're not actually talking about the science of pain. And sometimes that can be because it's so complicated. Sometimes it's so challenging. Sometimes it's because we just don't know what the words are to really connect with our friends and family to help them make sense of this. So that is another goal for this particular talk. And ultimately, though, my big takeaway that I'm hoping with this particular presentation is that we start thinking differently about pain. And you're going to notice that I'm going to use the word pain throughout this presentation. I will have a couple times when I say acute or chronic or persistent, but my big takeaway with this is I hope we think differently about pain as pain. Okay, not acute or chronic, just pain as pain. All right, so we're going to be covering 3 key pain concepts throughout this particular talk. The first one we're going to talk about is what the purpose of pain is, and this kind of helps make sense of why people can hurt, even if it appears nothing's wrong. And I know a lot of you guys have some insights on that based on the community that you're in, but we're going to talk about some other data and research around that. The second one we're going to talk about is what I find over and over again is the most common misconception about pain. Again, all pain, almost everyone makes, as certainly healthcare providers do, and this tends to cause treatments to fail. In fact, it guides a lot of the treatments that we do in the medical community, and I'm going to talk about that a little bit more in my background. And then ultimately, how can we think differently about pain for safe and effective treatment? Again, all pain. So who am I, and why am I here, and why am I even talking to you, and why should you even bother listening to me? So I'm Dr. Kevin Cuccaro, and my background is pain. So I did a residency in anesthesiology at the University of Chicago. And what's interesting about anesthesiology is that we deal a lot with pain. We deal it in the short term. We deal it before surgery, after surgery, in a chronic pain clinic. And it was a fantastic institution, and we learned a lot of really interesting things. It's a different institution. University of Chicago is kind of known as the nerds in the Chicago community because there's a lot of scientists thinking a lot about different things, but a great environment. Now, after that was all said and done, I did a fellowship in pain medicine at the University of Michigan. Again, another fine place, wonderful, wonderful people there. And then after I was done with that, I was sent to San Diego because the military had paid for medical school for me, and very quickly became the associate program director of the Naval Medical Center San Diego. Now, that's a very long way to say is if you look at my background, I'm what you would call a pain specialist in the medical and healthcare system sense of the word. I have all the certifications. I took all the exams. I did the oral exams. I taught doctors. I taught residents. I taught fellows. But ultimately what we really were was we were specialists in injections. And what I mean by that is through all this training, what we were really focusing on is how to take a needle and poke it into people and somehow try to make their pain go away or at least alleviate their pain. And why I say injection specialist, because I recently went back to one of my own textbooks. This is a 1,300-page textbook on pain medicine, and less than 30 pages in that book were devoted to the science of pain. The remaining 1,100 plus pages were devoted to procedures, medications, and a bunch of other things. And even that 30 pages really didn't touch on the science of pain. And how I got interested in all this stuff was I started asking, why aren't people getting better? Now, part of that was the environment I was in. I was at the military, and I had colleagues that practiced different than me. Some were very, very aggressive with injections, and some of us were very, very conservative with injections. But we couldn't hide our patients because we saw everybody's patients. We had this group practice, and so I just couldn't keep all my patients to myself and pretend that all their results were different. But what I noticed was we could do the same exact procedure on two different people with the exact quote-unquote pain, and you would have completely different outcomes associated with them. And we had some people that were getting better with really minimal intervention, and we had other people that seemed to get worse the more intervention that we did. And at the time, I thought it was the military system. We like to blame the structures that we're in, and then the military it was a great institution. I worked with some fantastic individuals, but I had some complaints about this group practice because I would not see all my patients. I would sometimes have procedures that were assigned to me for some of my colleagues, and I would probably have not done those procedures if it was up to me. So I thought this model of kind of discordant care was the reason that our outcomes weren't where I wanted them to be. So when I left the military, I chose a community on the West Coast in Oregon, and there were no other full-time pain specialists at the time. And so I had the perfect environment where now me as the specialist in pain, the magic specialist guy, I could see my patients, I could do procedures on them if they were appropriate, and then I could follow them up very, very aggressively. And what I recognized within 6 to 8 months is that my outcomes were essentially no different than what I was seeing in the military, meaning people would get better or they wouldn't, and it wasn't really clear why. And the other part about this is I learned that there's different words of the word better. So sometimes patients would come to my office and they would say, Dr. Cuccaro, I feel so much better after those last injections, but now something else hurts. And I would look into the chart, and if I had done injections in their low back, in the ensuing time since I had last seen them, the month after those injections, they may have seen an orthopedic specialist and got injections in their knees. And then month after that, they saw the rheumatologist and got injections in their shoulder. And the month after that, they're back to see me. And so while I couldn't say that they were actually better, they were saying they were better. But if you looked at in their medical record, they were getting more and more injections. Oftentimes the medications weren't going down. In fact, sometimes they were going up where they were getting more and more medications. Instead of seeing less healthcare providers and seeing less of the healthcare system, they were seeing more and more specialists and more healthcare providers and having more and more appointments. And so what I saw was these people coming back and getting more and more entrapped into the healthcare system. And now, since I was not in the military anymore, I couldn't blame the model and had to look at other variables, including my own variables. So I went back to the science. The first thing I wanted to look at was the procedures and the training that I had. What's the data behind that? Start questioning my assumptions of how my treatment style was. And that data was frankly shocking. And we're going to cover a little bit today on how we typically treat pain in the medical community. And then I had to make the hard choice. I had to make the hard choice of, I'm a pain specialist, but do I actually understand what it is that I say that I'm treating? And that is when I went back to the science of pain. And what I found was, frankly, again, shocking, because the science of pain has advanced tremendously over the last 20 years. And yet in a typical healthcare system, in the typical mindset, and really what the public is being exposed to is stuff that's at least 50 or 60 years old. So now, after all this is said and done, I do consider myself to be as a pain specialist and consultant. I work a lot with healthcare systems and healthcare providers. And the reason I've chosen to do that is because the more and more we can get healthcare clinicians involved with this and understanding how to see and understand pain and approach it and manage it differently, that scales. We can actually have widespread systemic change. We can start touching more individuals. We start spreading these results and seeing how things change. Now, that all being said, the healthcare system is incredibly resistant to change for a number of different reasons. But still, that's where my focus is, because I think that's where the largest effect is. Also with this, I've done a number of educational programs, worked with a number of different clinics in our area, had one of the largest pain education interventions in the nation. And through that work, I was recognized by the Oregon Health Authority. They invited me to become a clinical innovations fellow. And following that, I was invited to the Oregon Pain Management Commission, and I've been on some task force and things with them. Now, all that being said, though, and I forgot to put my disclaimer slides in here. So I will put a disclaimer right here. So to start off this, I apologize, though, I don't actually have the slides. Disclaimer number one, this is completely educational and informational only. Obviously, I am not your physician, and anything I'm giving you is general educational and information only. Whatever your actual medical condition is, you need to talk about that with your healthcare professional. Disclaimer number two is extraordinarily important, though. I do work, and I have been on state and regional task force, but what I want to emphasize is everything in this presentation and everything I am saying is coming directly from me. They're not reflecting on anybody else I've worked with, any other healthcare systems, any state agencies, or anything else. This is strictly me. All right, and with that being said, let's delve into the presentation here. So I wonder how many of you guys recognize this gentleman. And this is Dr. Ignaz Semmelweis. He is a kind of a cautionary tale for me in a lot of different ways, but he was a physician in the mid-1800s. And what was interesting about Dr. Semmelweis is his first job after his medical training was at a hospital for laboring women. It was an obstetrical hospital. Now, this was also a community hospital, so this is where typically the poor people went. And in that hospital system, what he noticed very, very quickly after starting was that women died. Now, that in and of itself is not too unexpected. Childbirth has been a very dangerous time. It has a high rate of mortality associated with it, including in this day and age, by the way. But back then, people were dying relatively frequently. And what he was shocked at was in his particular hospital, there were two wings. There was the wing where the medical doctors and medical students admitted women. And then there was another wing where the midwives admitted women. And they alternated days. And it seemed, in what he saw from the mortality statistics, was women that were admitted by the doctors, and so they were taken care of by the doctors and medical students while they were laboring and delivering babies, died at a dramatically higher rate than the women that were delivered by the midwives. Now, this shocked Dr. Semmelweis, probably because he had just started at this hospital, but the hospital itself didn't seem to notice it too much. But the community did. And what I mean by that is it was so well known in the community that when people were admitted by the doctors, they tend to die more frequently. Women would pretend that they weren't in active labor. They would avoid going to the hospital. They would try to delay their admission until the midwives were admitting patients. Sometimes they would deliver in the street in preference to actually delivering in the hospital. And so the community knew, and Dr. Semmelweis recognized this, and he started wondering, why are all these women dying? And so this was before germ theory, and this was before we knew much about a lot of the medical things that we know now. And so he started to experiment. He said, well, okay, let's see what the differences are. And one of the things he did is he thought, well, maybe the windows are closed and we need to open the windows because the midwives had the windows open more often. So he opened up the windows and the women still died. And then the other thing is when someone would die in this hospital back then, a priest would ring a bell and walk down in the hallways to signify that someone had died, and said, well, maybe people are getting scared to death, literally scared to death by hearing this bell. And so it's the bell that's causing all these extra deaths. So he stopped the ringing of the bell and people still died. And he was trying all these different things and women kept dying. And then a tragedy occurred. And it's important to remember that this particular era was the golden age of dissection. And so what the medical students and doctors were doing is they were taking the bodies of the dead people and then they were dissecting them for their education. And during this process, one of his good friends, who was a pathologist, cut his finger during a dissection. And about a week later, he died of symptoms that were virtually identical to those of what the women were dying from. And this made Dr. Semmelweis think. Again, this is pre-germ theory. This is before people had gloves that they were wearing. This is before sterile procedure. But he thought, well, maybe there's something that's being taken from these dead bodies, and we're putting on our hands these little particles, and we're putting those particles, and maybe that's what's causing these deaths. So he made everybody wash their hands. All the medical students and doctors had to wash their hands between their patients, and lo and behold, the death rate dropped dramatically. So much so that there were no deaths one month in the medical wing as compared to the midwife wing. So he was very excited, and he told all his colleagues, we must wash our hands. We must wash our hands. We're killing women by not washing our hands. And his colleagues all said, no, we are gentlemen. And then they threw him into an insane asylum. And one of the reasons for this is, you got to remember, this is pre-germ theory. They didn't have a good explanation for why. And at that particular time, physicians were high social status. These were members of the aristocracy. They were from upper middle income. And for him to say that their hands were dirty made them feel like they were common laborers out in the field. And they ridiculed him, and they basically ignored him. And it's so much so they drove him out of that hospital. Stopped all the hand washing, death rates went up. Dr. Semmelweis went to another hospital. He instituted the same policies, death rates went down, and he was driven out of that hospital, and death rates went back up again. And about 20 years after this, he got more and more vocal about his criticism. And then his colleagues then tricked him into an insane asylum. When he tried to leave, he was beaten, and 2 weeks later, he died of sepsis. So the long and short of this story is that there are assumptions and misconceptions, and these assumptions and misconceptions can be quite harmful. So what does this have to actually do with pain and pain care? Well, let's talk about the problem itself. Again, I do a lot of talks with the medical community, and we hear over and over and over again about opioids, opioids, opioids. But it's not an opioid problem per se. What we have is a pain problem. Because people don't write opioids just because they love writing opioids. We wrote opioids because we were concerned about pain. And we did it in a lot of ways because we were told that opioids were the best treatment for pain. And it's pain is the reason that we have this opioid epidemic. Now, pain is a common presenting symptom. It's the most common reason for Social Security disability. So people under the age of 45, the 3 top reasons for disability are back pain, neck pain, other musculoskeletal pain, and then the last 2 are anxiety and depression, which hopefully some of you guys see there's some tie in there, and we're going to talk about that at the end. We're spending huge amounts of money on the treatment of pain in both direct and indirect costs, so much so that we spend more on the treatment of pain than diabetes, cardiovascular care, in basically any other medical condition. And then the Institutes of Medicine in 2011 said we had over 100 million Americans living with chronic pain, which is a very scary number, but we're going to put that in context in a second. Now, back pain specifically is the second most common reason for all physician visits. Basically, if I was doing this in a way I could see you, I would ask if anybody in the audience has not had an episode of back pain. And then if someone raises their hands, I could look at them, and judging on their age, I can pretty much estimate whether they have forgotten the episode, because it's pretty much guaranteed if you have a spine that you've probably had back pain at some point in your life. And this is what the data holds, that the lifetime prevalence rate between 60 and 90%. Now, what's also interesting when it comes to back pain is that if you looked at the industrialized world, so United States, Canada, Western Europe, and things, and you compare it to the developing world, things like sub-Saharan Africa, the Amazon, things like that, what we see is every culture, every continent has back pain. But what is very, very different is disability rates. And when we're looking at chronic back pain and chronic back pain disability, this is a disease of the industrialized world. And so the question then becomes is why? The other thing I like to look at when we're talking about just pain and pain care is if I'm talking to my physician colleagues, I like to remind them that if someone walks into our office and says, you must do something to me, doctor, there are only 4 therapies that we can actually do to them directly. And do to them means that it doesn't require the patient to do any interaction, have any engagement, actually any participation. These are things that we can do to you directly. And we can look at you. That means x-rays, MRI, CT scans. blood work. We can poke you. That means we can take a needle or send you to a colleague that pokes a needle into you. We can cut you, so we can do surgery or refer you to a colleague that does surgeries, or we can drug you, which prescribe medications, or again, refer you to somebody else who's going to write those medications. And when those are the tools in your toolbox, these are the tools that we use. So much so that when we look at something like non-specific low back pain, where every guideline says you shouldn't be doing MRIs, we increase the rate of those by 300% in a 10-year time period. Procedures, the things that I used to do, increased over 130 to actually over 1,100%, depending on the nature of injection. Surgeries for back pain, where the indication is back pain and not people who can't move their legs or peeing or pooping on themselves, have neurologic conditions associated with that, or infections in their spines. But when the indication is pain, that increased over 300%. In opioids, the thing that gets all the press, between 1996 and 2004, the number of opioid prescriptions written increased 690%. Between 2004 and 2011, that number subsequently doubled. But that's just the number of prescriptions. The actual amount of opioid per prescription increased 1,148%. So a dramatic increase in both the number of prescriptions as well as the quantity of opioid per prescription. Now, what did we get for all these treatments, though? We actually have higher rates of disability to pain than ever before. We have higher rates of complication. I have a friend who's a complex spine surgeon. Some of you may be familiar with him, Dr. David Hanscom, who recently retired, but before he retired was seeing 2 to 3 patients every week that he was looking at the original films they should never have had an operation on. There's also patients that go blind during these operations, that die during these operations. Procedures that, again, the injectionists would like to say that they're low risk. In 2012, over, I don't remember how many hundred people had tainted steroid injected in their spines, and about 70 of them died. And the other ones then ended up with fungal infections within that intrathecal sac, which are extraordinarily difficult to get rid of. And when we look at the data behind these things, these were essentially unnecessary. Now, healthcare costs have also increased dramatically, so much so we're spending so much money on the treatment of pain that I like to tell people is we don't need any more money for healthcare. What we need to do is stop spending money on things that don't work and redirecting money to things that do. But the most important one probably for you guys is that we're not seeing improvement in self-reports. In fact, we're seeing more and more report of pain. So much so that when we look at our overall results, and we started in 2000, we had about 282 million people in the United States and 45 to 50 million people living with chronic pain. So a lot of people. But in 2010, we had 309 million people with chronic pain. And it was, again, estimated we have, or 309 million Americans and 100 plus million people with chronic pain. So that is an increase of 122% in the prevalence rate of chronic pain after dramatically more, quote unquote, treatment, surgeries, injections, and drugs. So the question that I would ask then is, if you actually have more and more of the problem after more and more treatment, what assumptions are we making? What is it that makes sense there? Yeah, because if you have more of a problem after treatment than you're starting with, there's probably something that you're missing. And to me, this comes down to what is pain. Now, again, I can't see you guys, but if I was doing this live, we would be playing this game called What is Pain? And I'm going to show a couple pictures here, and I want you to just, at least in your head or in the comments or in the chats or someplace else, unfortunately, I can't see it, but I'm going to show some pictures, and I want you to tell me whether or not this person's experiencing pain. So this one, I would be shocked if you haven't seen this picture because it gets wide use. But this is a 29-year-old builder. That's a 7-inch spike. That is a steel-toed boot. That nail is proximal to the steel toe going through the middle of that boot. And the question then becomes pain or no pain. And if you know this particular story, this man had a tremendous amount of pain. He was screaming in pain, taken by ambulance to the emergency room. In the emergency room, he received fentanyl, which is 100 times more potent than morphine, and a very strong anxiolytic, which works in synergy with an opioid medication. After he had those medications, he was calm enough that they can cut the boot off. And lo and behold, they discovered that the nail was between his toes. Now, when I was doing this locally and live, I would say, well, okay, so pain or no pain? And after people heard that he didn't have any tissue damage, they would say, oh, but he didn't have pain. And I go, well, that's really interesting. Because if you give someone a bunch of opioids and you put another, that benzodiazepine medication on top of it, and they're not experiencing pain, what tends to happen? And what tends to happen is they go into basically respiratory depression. They have an overdose of that opioid. They have too much of the opioid and they stop breathing. And he did not. So it's not that he didn't have pain. He had 100% pain. It was 100% real pain. But what he didn't have was tissue damage. He still had his heart rate going. He had adrenaline pumping through his body. He had all these things that showed that his body was under stress. But what he didn't have was any tissue damage. Now, this particular picture here, again, pain or no pain. And people look at this and I know it's not the greatest photo, but that is a nail through that man's thumb. And they go, pain or no pain here? And they go, well, I bet he has pain. And they'd be right, because he did have pain. Now, I actually pulled this, though, from a YouTube video. And the YouTube video is kind of funny because this man this was his 4th day on the job. He shot himself with a nail gun. Then somebody gets out their cell phone and starts recording this thing. And then the rest of the video is him working with his buddies, his coworkers, and they're trying to grab the set of pliers so they can pull the head of the nail back, cut it, so they can pull the nail through his thumb. And he's kind of jumping around, but there's lots of laughing, and he's like, ow. But this guy who has tissue damage with a nail through his thumb, and they're grabbing this thumb and pulling this nail around with a pair of pliers. What he didn't get was any fentanyl. He didn't get any benzodiazepines. And once they took out the nail, we're hoping that his tetanus shot was up to date. But I don't think he ever went to the hospital. Now, what does he have in difference to our guy with the boot is he does have pain, but mild pain. But he also has tissue damage. And then lastly, if we look at these 2 x-rays here, because this is common, people will get x-rays and say, well, where has the pain, or who has the pain? And so again, who has the pain here? And I know you guys aren't radiologists, but if you look at these 2 images, these are not the same. Now, they are both of the low back, so kind of the area below your ribs and just at the top of your thighs. And what you can see is the image on the left of your screen, that's what we would call lumbar scoliosis. So there's a curvature there. Well, the image on the right of your screen is pretty much up and down, and it's not a 10-year-old spine, so it's developed and has some age-related changes, but it's essentially normal. And if we're looking at this, and if I've done my job right, and I say, who has pain here? You should say, we don't know. And we don't. Because the lady on the left with that scoliosis, that's a 66-year-old woman. She does not have any back pain. And the image on the right, well, that's not an image of my patient specifically. It reminds me of a patient I had in the military, a 23-year-old kid who, quote unquote, back went out one day when he was in the boat. He was on high-dose morphine, had every procedure done to the sun. All his imaging was, quote unquote, normal. And yet he was complaining of severe pain. So then the question becomes then, how can someone have severe pain in their foot but no spike? They can have a nail in their thumb but little pain, can have spinal deformity, very visible on x-ray, and actually you can see this on physical exam as well, but they don't have any back pain, or normal x-rays and tremendous amounts of pain. Now, we can either pretend that the people who are saying that they have nothing on x-ray and have pain are lying, but they're not. They have 100% pain. It's 100% real. So we have to be able to explain this stuff. And interestingly, the definition of pain from the International Association from the Study Pain, published way back in 1979, is a pretty good definition. Because what it says is that pain is an unpleasant, it's a negative motivator, sensory and emotional experience. So we know that there's a sensory element, there's information coming up from the body, but that the brain and the emotion, the meaning, the mood, the memory is there as well. And these come together to create this experience of pain. And that pain is there whether or not you have tissue damage. We simply describe it in terms of tissue damage, meaning we don't have pain that's out in the air floating in the breeze. Pain is either in our back, it's in our shoulders, in our head, in our belly, throughout our body. It's a bodily sensation. Now, we can take this definition, though, and we accelerate it through the last 20 years of pain science. We can revise it a little bit to say pain is an unpleasant sensory and emotional bodily experience, except we describe it in terms of the body. But this response that we generate is response to perceived danger, not damage. And this brings us into key pain concept number 1, which is the purpose of pain is all about protection. It's not about punishment. That hurt doesn't equal harm. That physical damage doesn't equal pain. And again, that protection, not punishment, and that danger, not damage, starts to help to explain these pictures. Because if you had a steel-toed boot on and you hit the ground and you see the 7-inch spike through that boot where your foot is in that boot, how much threat do you think your brain sees? Well, if you have a piece of protective equipment that has failed, that's a lot of danger right there. Now, on the flip side, the guy with the nail through his thumb, which I think I neglected to mention, was this is not the first time that he'd shot himself with a nail gun. In fact, I have lots of pictures of people with nails through their body from using nail guns. This is extraordinarily common, and it seems to be, again, if I was in a live audience, I'd ask you, and I wouldn't be shocked if someone used a lot of nail guns, they probably did this to themselves. But if you've had an injury in the past that you have successfully recovered from then, and then you have a similar injury in the future, you know from your experience that you're likely to recover again. So there's significantly less threat or danger associated with it. And so what we see is when you have a high danger, high threat scenario, like 7-inch spike through your steel-toed boot, there's a lot of protection going on. But when you have a nail through your thumb, but you're like, I've done this before, we're going to pull the nail out, it's going to hurt for a couple days, but I'm going to be okay because last time I was okay, not a lot of threat or danger, not a lot of pain associated with it. And we've seen this verified experimentally in lots of different ways. So you can actually have physical damage without significant pain in things like distraction. So if you are walking through the woods and you're solving all the world's problems, and then you push through a bunch of bushes and you keep walking, and then you feel something kind of cold on your arm, and then you look down and you see blood, and you realize that those are thorn bushes and you got scratched and you tore your skin, that is physical damage, but you didn't experience pain. Another way to remember this is if you've ever had a bruise and you're like, where in the world did this bruise come from? You have had physical damage without an experience of pain. Other ones, because we need to be able to explain both the extremes: minimal scratches, bruises, maximal life or death scenarios. So again, I was a military physician. So how is it that people get in these high threat environments and they can be shot, they can have a limb blown off their body, and yet in that moment of time, and sometimes for time afterwards, they're not experiencing pain? How could you can get shot and then pull your buddy to safely and not recognize that you were actually shot while you're trying to do that heroic measure? And if we think about pain as damage, it doesn't make sense. But if we think about pain as a protector, it does. Because in a life or death event, when your brain is seeing threat and danger all over the place, and so much threat and danger, all it knows it needs to fight or flight or flee or freeze in that foxhole. In that moment in time, pain is no longer a protector. It would be a distractor. And so we were not going to experience it under those high threat environments. Another high threat environment, if you twist your ankle, you're going to usually experience pain. But if you twist your ankle and you have a bus that's bearing down into you, it's about to hit you, you're not going to experience pain, because that threat and danger of experiencing pain would actually distract you from doing what you need to do to escape that big bus that's going to kill you. Secondly, we have things like what we believe to be true about pain. This is my a personal interest in me. When we're looking at the effects of beliefs and pain and how this all interplays, it's absolutely fascinating. But what you believe matters when it comes to pain. So this was a particular study. What they did is they took hot and cold metal bars and they put them against the neck of volunteers. And they said, hey, thank you, volunteer. We're going to put this cold metal bar and we're going to put it against your neck. Tell us when it gets uncomfortable and when it becomes too painful, and we'll remove this cold metal bar. And they did that, and they discovered that cold metal bars become painful and they're uncomfortable. And so nothing too remarkable there. But then they took the same people and they said, oh, thank you very much. We're going to take a hot metal bar. We're going to do the same thing against you. They took the hot metal bar, and what they discovered there was hot metal bars are painful and they're also uncomfortable, and they're more painful and more uncomfortable, and people want them off their necks faster than cold metal bars. But the temperature of the bar in that study was exactly the same, just very, very cold. Because if you have something cold enough, what's the sensation that you experience? If you've ever played with dry ice or been outside on a freezing day, it's a burning sensation. So what they were manipulated, what the people believed that sensation was. And if you kind of think of it from a protection standpoint, if something is burning hot, typically that would cause us more damage than something that is burning and very cold, at least faster. And so what they, again, manipulating that variable, they found that people with the same stimulation, the same super cold bar, if they believed it was hot, had more pain sooner than people who thought it was a cold metal bar, which it actually was. Now, in both scenarios, though, what I want to emphasize, this pain is a 100% real. This is not fake pain. This is 100% real pain. It's just the pain changed in both of those scenarios. And then the last one is general anesthesia. If we take your brain and put it completely to sleep, lo and behold, we get this thing called general anesthesia, and now you're not experiencing pain. This is the reason that surgeons can do what they do when you're under anesthesia, is that your brain is not experiencing pain. Now, on the flip side, when can we have pain without any physical damage or without significant physical damage. Well, again, as we increase threat, not too high, not life or death, but the more danger that you're seeing, the more likely that you're going to perceive pain. So if you were ever a pool and someone had a glass and they broke the glass, and now you do not have your shoes on and you have to walk across this area where there's all these little glass fragments to put on your flip-flops. In that scenario, if you step on a tall, pointy rock, it's probably going to feel different because you're on heightened alert. You're actually paying more attention. There's more threat and danger from your feet. So a sharp pointing rock is more likely to be perceived as a very sharp sensation than a dull sensation because of that threat and that threatened environment. Other ones are expectation of harm or vulnerable expectations. So if we tell people an area is vulnerable, and they're more likely to perceive pain there. This was demonstrated with things with lasers, where they took people and they said, hey, we're going to flash lasers on, I think it was their foot, but I'm not exactly sure. And they basically said, oh, by the way, this area of your foot is very vulnerable to lasers. And when they changed the wording and told people they were going to flash this laser on something that was vulnerable to lasers, people had pain sooner and more pain than those who didn't. Where this also comes into play is if people have been told or believe that pain equals damage, and then we get an x-ray and tell them that they have severe disc degeneration, they tend to not move. They also tend to experience more pain, and they also tend to expect more pain based on what those imaging findings are and what they've been told and what they believe to be true about pain. So as we believe that pain equals harm, and we see this over and over again, the more that pain not is associated with harm or can be associated with harm, but pain equals physical damage, the more pain people tend to experience, the more severe it is and the longer it lasts. The key part about this, and again, I know in this particular community, you've talked about this before, is that pain is not the same thing as damage. But more importantly, that pain isn't about punishment, and pain is not trying to do horrible, awful things to you, but instead what pain is trying to do is protect you. Now, the problem is it sometimes does it in inefficient or ineffective ways, kind of like a helicopter parent sometimes is doing things that aren't in the best interest of the kid. And so your brain is trying to protect you, but when it starts to see threat in areas where it shouldn't be seeing threat, this is where some of the problems arise. Now, let's move slowly into key pain concept number 2. And as I can't see you guys, but if I'm talking too fast, someone let me know, and Sarah, feel free to slow me down because I do have a tendency to talk real fast. But we're going to go into this misconception about pain that is super, super common. And again, I just want to remind everybody, it's these assumptions and misconceptions. When we stop thinking about things that are so obvious, that they're so obvious that why we even have a discussion? Why would we even question on them? That's when the errors get made, because those assumptions can often be not the right one, and some misconceptions there as well. Okay, I was just looking at the chat box here, and so far we're doing good. Okay. So again, and just a reminder, Dr. Semmelweis, because everybody assumed back then that doctors' hands were perfectly clean. There's no way that they needed to wash them, and lo and behold, we killed hundreds, if not thousands, of women because of that. All right, so what's a common misconception about pain then? And I hear this, and we use this all the time, and there's some reasons that we use this particular verbiage. But when we say, where is the pain coming from? And we see this particular picture here, where's his pain coming from? Again, so he's got the nail through his boot. He has no tissue damage. And people say, well, his pain must be in his brain. I say, absolutely, his pain is in his brain. But where is this gentleman's pain coming from? Now he has a nail through his finger. Where is his pain coming from? And people say, oh, his pain is coming from his thumb. Well, no, his pain is actually in his brain as well. The only thing that's different is he has a lot of different sensations coming up from his body as well. But his pain is 100% in his brain as well, because he doesn't have, if pain was not within the brain, then the amount of tissue damage that you had would tell us how much pain that you had. And we know that that's not true. Instead, it changes on a bunch of different variables and is not strictly dependent on physical damage. Or these two pictures, where's the pain coming from here? Again, the person who we would say, oh, she's got scoliosis, your pain must be coming from a scoliosis, except she doesn't have any pain. And on the other side, we have someone who's got the normal x-ray and has got severe pain. So if we believe that pain has to come from a structure in order for it to be real pain, this doesn't make any sense. And the other way to consider this, if pain actually came from, I call it pain pus, if pain oozed like pus out of the body, down pain receptors, down pain pathways and pain nerves and anything else, like it was unadulterated pain going from the body up to the brain, then pain treatment would be super easy, because all we'd have to do is an x-ray and MRI, and we would see the pain generator, and we would be able to consistently and predictably detect who is and who isn't experiencing pain. But is that true? And it isn't. And this particular, you guys may have seen this before, but this was a study where they took people who had no back pain, asymptomatic patients, and then they did MRIs of their back. And then they looked at the data, and what they basically said is, if you have a back, you're going to have age-related change. So again, people without any sort of back pain at all, in their 20s, 37%. So 1 in 3 of them had disc degeneration. Other severe findings like protrusions and things like that. Again, these people don't have pain. So it is not a one-to-one correlation with structure and pain. Pain doesn't ooze out of these discs. Pain doesn't ooze out of the hip or the body or the brain or the head or anything else. But so it's key when we're talking about the terms of coming from, we're not actually talking about pain. Other ways, again, if pain actually came from, ooze like pain pus, then all we'd have to cut, poke, pop, drug those pain pus pathways. And again, therapy would be easy, because surgery would be 100%, almost 100%. Injections would be almost 100%. Drugs would make things really, really easy. And consistently and predictably, we would have people without any pain or significantly reduced pain. But is this true? Well, we certainly know it's not when it comes to surgery for back pain. And in your own surgical literature, they have no idea who fusions work for if the person has had back pain that has been longer than 3 to 6 months. That's their own surgical literature. That we have no idea who it works for. It's not predictive. It's not effective. Do some people get better? Yes. Do a lot of people not get better? Yes. Why do people get better? It doesn't seem to be because of the fusion per se. And then when we look at our treatment model, MRIs and x-rays are all to look at and find, quote, pain pus generators. Procedures, the things that I used to, again, we would numb up and try to, quote unquote, find a pain generator. We would burn nerves to stop the flow of the pain nerve down the pain pathways. We do surgeries or fuse segments to stop the pain flow. And then opioids tend to be written when people would have degenerative conditions in an attempt to stop this flow of pain pus. But the model doesn't work because we have higher rates of disability, higher complication rates, massively increased healthcare costs, and people, by what they're reporting, are not getting better. So maybe our model of understanding pain needs to change, because this idea that pain oozes down pathways or from pain receptors is really almost as old as the 17th century. So the diagram on the left of your screen comes from René Descartes. He wrote some really interesting writings way back in the 1600s. And the idea that you could poke or pull a tissue or segment, and then the pain would flow up to the brain, that's really 17th century old thinking, that the pain comes from or comes down these tracks. While in the 21st century, what we recognize on the right-hand side of the screen, that's a diagram that is revised from Ron Melzack, who is sort of one of the huge big guys in the pain science world, him and Pat Wall. But this is neuromatrix theory, and recognizing that pain is both more complex than we give it credit for and is not 100% related to tissues. In fact, we have all of these other contributors here. We have not just specific types of sensory input coming from the body, but what you see, what you smell, what you hear. We have your brain input, things like memory, mood, the meaning that we give. We have dynamic brain input, which has to do with threat appraisal and attention and what we expect to occur. We have our immune system. We have our endogenous opioid system. We have the sympathetic and parasympathetic neurosystem. We have internal state information, but it is all these different inputs that are coming together in order to construct an experience of pain. And so key pain concept number 2 is that pain does not come from the body. It doesn't ooze out of a structure. It doesn't come out of the disc or come out of the shoulder or come out of the belly. Instead, all pain, whether it's new pain, broken leg, or back pain for 50 years, all pain is constructed into the brain. And that's really the only way that we can explain things like people who have nails through their boot that have severe pain, people that have nails through their thumb and have minimal pain, people that have normal x-rays and severe pain, people that have abnormal x-rays and no pain, Or even in scenarios when people have legs, like broken legs. If anybody, there's a basketball star who broke a leg, had a compound fracture, no pain. Now, again, the only way this makes sense is the brain has to be implicitly involved in this whole process. And the second part is that more we know is the more scared, upset, uncertain, stressed, and threatened people are, the more pain they tend to experience. Again, unless it's life or death issue. Now, how do then we construct pain? If we look at our definition here, unpleasant sensory and emotional bodily experience in response to perceived danger. And then we take Melzack work with neuromatrix theory and we see, wow, there's all these inputs. This looks really, really complicated. But we can basically divide this into three key dimensions to construct an experience of pain. The first one is that sensory aspect. That's the feeling. Where is this? What is it like? Is it in my, do I think it's in my toe? Do I think it's in my belly? Do I think it's in my shoulder? Where am I perceiving the sensation? And what are the characteristics? Is it hot? Is it cold? Is it burning? Is it squeezing and things like that? But that sensation alone is not pain. The second part is the emotion, the meaning to it. That's the blue right there. That is like the oxygen here to this pain, where it says, what does this sensation mean to me? Because the same burning sensation with a different meaning can have dramatically different experiences to it. If you love hot, spicy food and you have a burning sensation on your mouth, that could be a very good thing. You may be excited. Oh, I'm eating these hot peppers and this is the best thing in the world. If you hate hot and spicy food, and then you have a burning sensation in your mouth because maybe you accidentally bit a pepper, same sensation, dramatically different meaning though, because you hate these hot, spicy food, and dramatically different experience. And then lastly is the cognitive element. Does this sensory information even matter right now? Is it important? Is there a bus bearing down on me? Is there a war zone in my who else is around me? And also involved in what is the next action to be. So when it comes to pain, instead of thinking coming from this cause and effect or unidimensional or even two-dimensional kind of thinking, I encourage people to start trying to see it, again, whether you stub your toe or you have 30 years of back pain, in 3 dimensions, and appreciate these 3 dimensions. Now, this may seem a little bit confusing because, my God, how are you supposed to think in 3 dimensions? But there's a group of people who are already doing this, and those are firefighters. And what firefighters understand is every fire is unique, and every fire is dynamic, is constantly changing, but every single fire is constructed of 3 key contributors, meaning that image on the left of the screen is what is called the fire triangle. In the fire triangle, all firefighters learn this, and all firefighters understand this, and all firefighters apply this when they're actually out fighting fires, because they recognize that all fires have to have these 3 key elements. And if you can take away one of these key elements and disrupt this process, you can stop the fire from occurring. So fires have to have fuel, fires have to have oxygen, fires have to have heat. So you can cut the fuel source, you can cut the wick off of the fire, you can put a candle over it and a jar over the candle and take away the oxygen, and the fire goes out. Or we can put water on it, which actually targets the heat. And when we take away the heat, we take away the fire. Now, pain is similar. So like fire has the fire triangle with fuel, oxygen, and heat. Pain really has a pain triangle where you have sensation, again, burning, sharp, cutting, squeezing, gnawing, etc. But that sensation is just a potential fuel source. Then we have that cognitive element, which is the heat, the attention, the appraisal, the beliefs and expectations to it. And then we have the emotion, which is the oxygen to a pain fire, the meaning that we give, the memories that are associated with it, the emotion that it has. And as we change those variables, we change how pain is constructed. Again, just kind of reiterate there that these 3 key components, that emotion is the oxygen, that attention that we play is the heat, and then that sensation, which we spend so much time focusing on, is really just the fuel source. But as we change any one of these elements, we change the experience of pain. So that heat element, again, that has to do with threat. How much threat do we see? There's a difference if we have an accident occur and then we experience pain versus an intentionality behind it. So if someone accidentally runs and bowls you over and you fall to the ground, that may hurt. But if someone, and you think that they ran into you intentionally and hit you onto the ground, same force, same impact, but different intentionality behind it, your experience is dramatically different. Uncertainty and anxiety. There's a reason that we tend to see pain and anxiety lining up. And the reason why, the more anxious that we feel, the more heat that we generate, the more pain we tend to experience. Uncertainty is another big one, because the more uncertain you are, the more uncertainty about what this means, what this experience, people understand me? What is this pain? Is this something awful? The more uncertainty that we have, the more heat we have, and the more change we have with the experience of pain. And we tend to increase it with that uncertainty. The sensory aspect, the fuel, there are many, many different nerve agents involved with this. So we have different sizes of nerves that go from the body to the brain. We have small ones, big ones, and we have ones that are coated with insulation, ones that are not. But those are not just the only information that comes to our brains. We have information on internal state. So what does our belly and our heart and musculature feel like? We have information that tells us what the outside looks like. So that would be sight, sound, smell, all of which have an input when it comes to constructing pain. We have proprioceptive information that body tries to use to line up where your hand or arm or legs are in space and put that in relation to what they see so that we can walk and move and catch balls. And then lastly, we have the emotion, the oxygen, and this is heavily influenced upon the meaning that we give to a sensation. So things like fear is a big one. Abdominal pain. So an example I'll use is if you've ever eaten too much food and you've stretched your stomach out, just jam-packed it with too much food, you're going to have a lot of sensory info going from your belly up to your brain. It's going to say, hey, you put a lot of food in me. We've stretched way too far. We're going to have some bloating. We're going to have all this other stuff. Something's going on here. Now that sensation though is simply just a fuel source, because then you look around and then you start appraising where you are and you see a half-eaten turkey and 14 pies and family members that you only see once a year. And now the meaning becomes, this is Thanksgiving. And so while that stomach may be unpleasant because it's so distended, has lots of fuel, you don't have a lot of heat because there's not a lot of threat. And the meaning is actually, this is kind of a good thing. This is Thanksgiving. This is what we do. So you'll be bloated. You pop your, the top button of your jeans and you go watch football or talk to your family. Now, if we have that same sensation though, that belly bloating and that really uncomfortable sensation coming up from your belly, but now you don't know why. So now we're adding uncertainty in here. We have a little bit of heat. And then we go see our physician and they go, I don't know why either. Let's get a CT scan so we can see whether or not this is cancer. And we hear the word, this is cancer. Now we have a similar sensation of bloating, a similar sensation as we had when we stuffed that belly, but now the meaning has changed. And as most people, when they have a fear and uncertainty around cancer, that's going to be a lot of, every time you feel that bloating, it becomes, this is cancer building and bloating and spreading through my body. So a dramatically different experience because we've changed that oxygen supply to that pain fire. Other ones, which we don't have time to get into today, are things like anger or perceived injustice. The more rage, revenge, the more we feel that this was done to us and loss associated with it, the more that we have a tendency to experience more pain because there's more oxygen supply to that pain fire. So then the question then becomes is, what is this? And again, if I was live, I would look out in the audience and have someone say, well, this is firewood. And I would say, absolutely, this is firewood. And more specifically, this is a fuel source. But nobody actually touches a piece of wood, even though if we describe it as being firewood and says, ow, I'm going to burn myself, or put a piece of wood in a stove and assume that's going to heat the house. We know that this is only a fuel source. And in order to actually construct a fire, we have to have two other elements. We have to have oxygen, we have to have heat, and the fuel source in order to have a constructed fire. So in the same way, though, what is this? Now, this is your femur. This is the top bone of your leg. This is one of the most difficult bones in your body to break, and this is a displaced femur fracture. And if I ask you, what is this? And someone says pain, I'm going to say, no. All this is fuel. This is potential fuel for a pain fire. Because in order for this broken leg, severely broken leg, in order to have pain with this, we still have to have those other two elements. Again, we have to be paying attention to it. We have to see threat, and we have to have meaning associated with it. The structure or sensation alone, whether it's a broken bone or something else, is not the same thing as pain. So again, key pain concept number 2, pain is constructed, requires three-dimensional thinking to really kind of understand it well. It doesn't actually come out of or ooze out of a structure, whether the structure is a bulging disc or your brain, because some people are going around telling people that their brains are oozing pain now. All right, so we've covered pain is about protection, and as we change threat, we change the experience of pain. concept number 2, pain is constructed, doesn't come from. So we're thinking, whether it's a new pain or old pain, what are the potential threats on all different levels? Do we see a physical threat? Do we have an emotional threat? Do we see a cognitive threat, a social threat, spiritual threat? Where are these threats? And what is their interplay into constructing this pain? And this then leads into key pain concept number 3, which is how to think differently. So if you guys are of age, you may remember the first Gulf War in 1991. And as the Iraqi army retreated from Kuwait, what they did was a scorched earth campaign. And they lit all the oil wells on fire. And they did this for a number of different reasons, but it was an economic and ecological disaster. They had over 700 oil wells burning. There's smoke and everything going through the air. And they were anticipating that this was going to take over 5 years before this was going to get under control. So they put out a call to get all the firefighters and people to come in and actually combat these fires in some very difficult locations in some scenarios, and some dramatically massive fires when you're looking at some of these images here. And within 9 months, all the fires were extinguished. Now, how did they do that? Is firefighters actually understand fire. And they recognize if you understand the process that you're treating, you can start devising new and different ways to quote unquote treat it. So you start looking at the resources that you have in the environment that you're in order to target the process that you know how it's put together. And so what they did was they started doing things like, if there was no local access to water, sometimes they say, well, we have an oil pipeline. Let's reverse the flow. We'll pull water from the Gulf. We'll reverse the flow of these pathways. Other times, when they didn't have access to water like that, they would put bombs. They had access to a lot of explosives. They would circle these oil wells with basically bombs, bring them in as close as they could, and then ignite them. And then that boom would basically snuff out, would remove the combustion from the fuel source, and they would blow out these oil wells like a gigantic candle. But the key point being is they understood fire first, and then they started targeting their treatments to the fire that they had in front of them. Now, I'll contrast that to our results, though. So 700 plus oil wells, 5 years, and they did it in 9 months. For us, we started with 45 to 50 million people with chronic pain. We ended up with over 100 million people with chronic pain 10 years later, despite increasing the treatment that we did. So maybe we need to think a little bit more like firefighters. And this leads to key pain concept number 3, is if we actually take some time to actually understand pain and how the science works, then we know how to treat it, or at least identify new potential areas where it have been either neglected or maybe didn't make sense where we would do therapy before. Again, firefighters understanding fire first, deconstruct it. They're not going out. They're not saying we could spray water on this. We could spray water on this. Instead, what they're looking for is, what is this fire in front of me? How is this constructed? And then what makes sense to target first, and then what next? Because they recognize if you do the same thing, or try to do the same thing, or just do the same thing because that's a tool in your toolbox, in some situations it's not going to be the best thing to do, and in some situations it's the dangerous thing to do, like throwing oil on or throwing water on an oil-based fire. Now, the same thing then applies to pain. We can deconstruct it to see where these contributors or the major contributors are. So if you look at our spike in the boot, and we have our fuel source, the first thing that we want to know is whether it has a tissue issue or no tissue issue. Is there tissue damage, or is there not tissue damage? And there is no tissue damage. So then we go, well, where's the sensation then? Well, if you kind of think about this, if you've ever jumped and hit your feet flat on the ground, you tend to get a sting, right? Well, that sting is a very specific type of nerve that is designed to grab attention, that says, hey, something new just happened to us down here. Maybe you need to take a look and kind of evaluate what's going on. That nerve tends to fire fast. It can be, as we increase the stimulation, it wants more and more attention from it, but is very, doesn't last very long in most scenarios. And so here, you can imagine, he feels a sting, he hits the ground. Next thing he does is he looks and he sees this going through his boot. And he goes, whoa, okay, I have a big nail through his own. Now, does he still have sensation coming through his brain? Yeah, because if I took a pencil and stuck it between your toes, what sensation would you have? Is that a normal sensation for you? No, it'd feel kind of weird, kind of odd. Typically, we wouldn't say it was painful, but you would have an abnormal sensation coming from your foot up to the brain. And if you see that and you feel that, and now you know that you have a steel-toed boot and you see this 7-inch rusty spike going through it, how much threat do you think you're going to perceive? How much uncertainty are you going to have? How much anxiety are you going to have about what that nail can potentially be doing to your foot? So lots and lots of heat. And then lastly is the oxygen. Now, this is much harder to kind of ascertain or even to extrapolate without talking to the individual, because this emotion, this meaning, is heavily based on what our past is, what we've learned, what we've associated with, what our memories are, mood, etc. Food, or fear, loss, and harm, and meaning are huge ones. History of trauma and things like that. If he had had a friend or family member that had lost his foot and now he was thinking, I'm going to get flesh-eating bacteria, and scared of flesh-eating bacteria, that would be a lot of oxygen. Or if he, another way to think about it is he has fear associated with this because maybe he doesn't have health insurance. Maybe he's terrified that with this injury, he's going to lose his house because he's had difficulty paying the bills, and maybe he's behind on his house payments. So all of these other contextual threats start coming in to construct his experience of fire, or his pain fire here. Now, visually, what would this look like? Well, you still have to have sensation, but we have a small fuel source. We have a lot of heat. And we have a lot of oxygen. Now, this is a big, big pain fire. But how we target it there is, wow, if we can take away that heat, if we can make him feel safe again, we can take away that uncertainty, and lo and behold, you take the boot off and he realizes his foot isn't damaged at all. Boom, there is no more experience of pain. Now, nail in the thumb, we go tissue issues or no tissue issues. And yes, he's got tissue issues. He actually has a nail through his thumb. How much threat, uncertainty, and anxiety, though, is minimal, because remember, we talked about how he has had similar injuries in the past. He's recovered from it. Other parts about this is the people around him have had similar injuries and have recovered from them and are telling him he's going to be okay. In fact, they're laughing and joking with him. So there's not a lot of contextual threat around him. And then lastly, that fear, loss, harm, or meaning, again, this is heavily dependent, but he recovered from it. So he has that history and memory of recovering from similar injuries in the past. This would be different if he had a friend or family member or himself who had lost maybe a thumb because of a horrible nail injury into his thumb in the past, or an infected thumb, and lost it. But for him, not a lot of fear, loss, of harm, or meaning. So not a lot of heat or oxygen. So when we look at his pain fire, we see lots of fuel and very little heat or oxygen. So again, once you pull the nail out and you wash it and make sure he doesn't, the wound is clean, he's probably good to go. He'll probably be okay. What about normal spine? We say tissue issues, no tissue issues here. And we can say, well, he has a CT scan, he has an MRI to look at the soft tissues, and they're all quote unquote normal. There's no infections. There's no torn ligaments. There's nothing in there that is an acute. So tissue issues or no. So no tissue issues, but does he still have sensations from his back? And absolutely, positively he does. In fact, if you're sitting down watching this presentation, I'm not exactly sure how long we've been talking for, but at some point your body's going to be saying, oh my God, I've been sitting for a long period of time. You may want to move in your seat. You may actually have some sensations coming up from your back. Those sensations may not say tissue issue sensations, but there's still sensations coming from the back, and you can have a normal sensation if with enough heat and enough oxygen, we can start burning fuels that aren't normally used as fuel. So if we have a blowtorch and we put it on a table, and the table doesn't generally burn, if you hold that torch there long enough, lo and behold, we can start burning fuels that aren't normal fuels. Now for this guy, what about heat for him? Threat, uncertainty, and anxiety. Well, if you have somebody with severe back pain and now they have an x-ray and you say, well, your x-ray looks fine, I have no idea where your pain is coming from. Does that make you feel better? Or does that make you feel more anxious? Because you have really bad pain, severe pain, but now this person's maybe questioning you, maybe you think that they're judging you, maybe you think they don't believe you, and then you have real pain. Maybe there must be something else, something being missed. There's something horrible that's taking place here. So lots and lots of uncertainty with this, and lots of anxiety when people have normal imaging and severe pain. And then lastly is the meaning, the oxygen supply to this pain fire. Fear, again, loss and harm and meaning. And the reason I have that bolded is because if you look over and over and over again at the back pain literature, and particularly chronic back pain and back pain disability, this is a big one. It is associated with really bad outcomes when you're looking at back pain. The more people are fearful of pain or associate that pain equals damage, the less movement that they do. Lo and behold, when they move again, we send different sensations up to the brain, becomes this kind of catastrophic cascade where they stop moving, they stop feeling safe in their bodies, they start believing their backs are vulnerable, and that when they're experiencing back pain, that their spine is disintegrating or causing damage. So lots and lots and lots of oxygen with these. And so when we typically kind of explain these pictures, we look at, this is a big pain fire. This is 100% real pain, but as an oxygen driven pain, it makes sense to start taking away the oxygen supply to this particular pain fire. Now, scoliosis, we go tissue issues or no tissue issues, and this is actually a trick question. So because she has that degenerative change, is that scoliotic curvature. When we're talking about tissue issues, we're talking about a specific type of nerve fiber that fires when there's acute tissue damage or threshold, when tissues get to the place where there might possibly have damage. So again, if you hit the ground and it changes those tissues very, very abruptly, you're going to have that stinging sensation. If I hold my thumb down and into your thigh for a long period of time, at some point, you're going to start getting a different sensation and aching from it. And that's because a different type of nerve fiber is saying, hey, you've been doing something too long and this needs to change. If you've been cut, these nerve fibers tend to go, or even if you get slapped, these are the nerve fibers that start to fire. Now, in this scenario, though, she doesn't have those. Now, she has age-related change, but she doesn't have that acute, what we call nociceptive or primary nociceptive information in the scenario. But she still has normal sensations coming from her back. Threat, uncertainty, and anxiety. Again, no threat, uncertainty, and anxiety. Luckily, she didn't have an episode of back pain, and someone told her it was oozing out of her scoliosis. Fear, loss, harm, or meeting, again, none. So again, she doesn't have any pain. And so I just want to remind us again that despite the fact that she has the severe scoliotic change, she has no pain. So structure does not equal pain. Now, she could also have severe scoliotic change and she could have back pain, but it doesn't mean that the pain is oozing from that scoliosis. The scoliosis could be contributing to it, but you have to remember those other two dimensions when it comes to understanding how that pain is constructed. Again, so tissue damage is not the same thing as pain. And similarly, and one of the things I wanted to bring to this community is rather than talking just acute or chronic pain, is recognizing even in an acute pain, if you have a new pain, it doesn't necessarily mean that you have tissue damage. All acute pain, all new pains doesn't mean that there's wood burning, that there's fuel source burning. And when you have chronic pain, it doesn't always mean that that's just a brain fire. We have to be remembering all these other elements as well. And I'm also not saying, though, because people have accused me of this in the past, as saying that structure or feel are irrelevant. And I never say that. You always have to be taking into question the sensation element, that body-based element. They're not irrelevant. Like in this acute scenario where this guy has a femur fracture. And the one thing I explain this with my colleagues who are like, well, when do I do surgery? In this scenario, if you saw something like this, or this was you, the way to kind of understand medical care is whether or not pain was present, would you want to stabilize that fracture? And the answer is yes. Because if you're a physician and you saw someone with a broken bone like this, even if they weren't experiencing pain, you would want to put a rod and you would want to repair this displaced fracture because this is actually dangerous for a host of different reasons. So we're not ignoring the body. What we're doing is we're thinking about it in different terms. We're noticing it as a contributor, but we're not using it as the mainstay of, if you have leg pain, whether or not you have a broken bone, we're going to chop your leg off. That doesn't simply make sense. When we're looking at persistent pain scenarios, so pain that has been persisting for long periods of time, the key thing to remember here, and I think most of you guys already know this, is that the structural elements or that sensory aspect is generally not the primary contributor. Because it can be there. You're going to have a sensation. You always have that sensation to it. But when we're looking at these long-term scenarios, almost always we need to be looking at the heat and oxygen elements there as the primary contributors, the primary maintainers of that experience of pain. This is also a different way of thinking, though. Thinking as pain is constructed versus coming from something. You have to be able to look at images, talk to people, and be able to say their pain is pain. All pain is pain. All pain is real. It just is a matter of how it's constructed that really determines what we're going to do next with this. And it isn't, again, this acute or chronic. There's a reason. I kind of ghosted around and looked at some of the comments that people have said. There's a reason that if you're doing those exercises through the Curable app, that you may have been noticing that other things get better. And it may be that if you even have stubbed your toe, if you've been using sort of those curable tool sets, you may have noticed that even what should have hurt more or may have hurt more in the past hurt less, because pain is pain, whether it's new pain or old pain or been for a long period of time. It always has these three components to it, and we can always target these three components in different ways. Again, and just to emphasize that people will typically say that image on the right, oh, you have lots of heat and oxygen, or you have central sensitization, that's all chronic pain. But these are both acute scenarios. So it's not either or, it's basically how is this pain constructed that becomes the big thing. Is there lots of heat, lots of oxygen? Or is it a lot of fuel because there's a lot of tissue information coming up? Or is it all of the above? Because when I'm working with physicians and healthcare clinicians, you know, if someone has all that heat and oxygen and then they break their leg, so now they have a lot of fuel, you're probably going to want to treat that a little bit differently than someone who doesn't have a lot of heat and oxygen there. And also recognizes there's different primary targets depending on the pain that is there. On the person that is, you know, who you are, your pain is unique. But we can sort of start deconstructing it to see where those primary elements are and where we should actually target in the healthcare system or not, or somewhere else. What's the primary target there? So again, if you have pain that in a lot of oxygen, we have depression, we have past trauma and things like that, it makes sense to start targeting and making sense of why that past trauma contributes and is heavily involved oftentimes with constructing experiences of pain, targeting that rather than put that person who doesn't have that tissue associated stuff through the ringer and start doing a bunch of injections and things on them, making it worse for a lot of different reasons. On the flip side, if you have somebody who's got a broken leg, or there's a nail in their thigh, we're not going to try to say, I want you to think your way out of this. It makes more sense to pull the nail out of their thigh. Now, is that the only treatment that you do? No, because there's always multiple others. So if a person's got a nail in their thigh and you can't take it out in the moment, would we say, well, there's nothing we can do, we have to wait until we can pull the nail out before you can do anything for your pain? No. We can start helping them feel safe. We can do reassurance. We can start directing their attention. We can use humor. We can start doing all these other things, whether it's acute or chronic, because there's, just like a fire is dynamic, pain is dynamic as well. And there are multiple different areas that we can target in any given scenario. Now, the most important though, and when we're looking at things, particularly risk factors for pain, again, I know this particular community, you guys are keyed into this, which is excellent because the rest of the world isn't that much. And when we're looking at these risk factors, often they're underappreciated in the outside world because we know, yes, there is some genetic influence on pain. It has to do with both the way the brain processes information as well as specific nerve fibers, but it's very small. And what I like to talk about genetics is basically, genetics is not predestiny. All genetics implies is a possible vulnerability. So it's not destiny. It's just maybe a little chink in your armor there. But the biggest ones that we need to be concerned about are the developmental ones. And what do I mean by this? These are things like childhood illness, childhood abuse, neglect, which is a form of abuse. And it doesn't matter whether it's emotional, physical, sexual, psychological, whatever type of abuse. The earlier the brain is in its development, including women who have babies, or so the pregnant women under high amounts of what I would call distress, so high threat-based stress, the brain's, the fetal development of the brain in that situation starts to change. And the way to kind of help explain this is if the brain is in a high threat environment and it wants to survive, right? The whole thing about the brain and body is like, what can I do to protect this organism? This is me. I love me and I want to protect it. And if you're coming from a background where there's lots of threat and lots of danger, it makes sense for your brain to start seeing danger easier. Because if you come from an environment where you have your mom works the midnight shift and the door to your bedroom starts to turn at 2 a.m. and you don't know, your brain does not know whether or not it's your mom coming home to give you a kiss goodnight or it's your abuser coming in because they know their mom is not there, your brain is going to try to protect you. It's going to see threat because it's, from a survival standpoint, it makes things to see threat first, react, flood the body with all that adrenaline and cortisol and get ready for bad things, and then back off if it's not there, rather than to assume that everything's going to be fine and then have to generate that response later on when it notices things are bad. So you can kind of think about when we're looking at things like ACEs, and we're looking at things like, which is adverse childhood events. And the more that we have this early childhood, the brain is not broken. The brain is not damaged. What the brain has become is hypervigilant and sensitive to threat. And this makes sense because it was trying to keep you safe during that time. And as we get older, it's still trying to do the same thing. But like a helicopter parent, it doesn't understand that it needs to back off because you're no longer in that environment anymore. So your people are not broken with this background. They're just more threat sensitive. Now, unfortunately, this tends to lead into things like adult victimization as well. When we're looking at things like PTSD, though, post-traumatic stress disorder, again, if you're thinking about pain as a protector, what is it, if you're in a horrible, awful event, what do you think the brain's going to try to do? Not only is it going to ignite that sympathetic nervous system in that moment of time, it's going to want to flashbulb that and make a memory saying, if I'm in a scenario even close to this, I need to remember it so that I can protect myself then in the future. And again, so this is related to these high stress when we're seeing, particularly the earlier it is, but it can also be later in life as well. Now, other risk factors, anxiety and depression. Now, when we look at anxiety and depression, though, what are the risk factors for anxiety and depression? They're the same things on the left-hand side of the slide. So there's a reason that we likely see anxiety, depression, and persistent pain all coming together, because the best way to describe it would be the wiring, the way the brain is starting to develop. These are all very tightly interplayed. The things that are going involved with anxiety, the things that are involved with depression, and the ones that are involved with constructing pain. Now, I don't have on this slide because I don't like to talk about it. I don't really like to talk about opioids or addiction because I think it overshadows and there's too much baggage associated with this stuff. But when we're looking at addiction and we look at the same thing, the risk factors for addiction are the same risk factors on the left-hand side, as well as anxiety and depression. And this probably has to do with the wiring, the plumbing that's involved, how the brain starts to change. And that is heavily dependent on how the endogenous opioid system changes, our internal opioid system. We make natural opioids and they're involved with all of these processes as well. Other big ones, though, what we believe to be true about pain and what we expect to occur are huge impacts on on our experience of pain and how we recover when it comes to pain. And then maladaptive coping, which is what we call passive-based modalities. When the more maladaptive coping is basically you feel like there's nothing that you can do for yourself. You feel helpless. You feel without control. Now, if you kind of think about that, if you feel helpless, without control, and unsafe, do you think your brain is going to perceive more or less stress? So if we take away a sense of control, we increase threat and danger to the brain. Active-based coping or active resiliency strategies, when you have been taught or you're learning or you're developing a skill set, so such as the skills that you're learning through the Curable app, when you're developing that skill set, not only are you using that skill, but you're actually training your brain that there's things that you can do for yourself. You're returning a sense of control. And the more control that we feel, the more that we feel we understand these processes, the more we feel we have tools that help us to overcome them, the safer that we feel. So where in the pain triangle, though, if we're thinking about all this stuff, and we're thinking about, well, where would that play in cognition? Is it heat, oxygen, or sensation? All those risk factors are heat and oxygen. And so they're not necessarily related to that sensation. They're related to how the brain processes information. And again, this is both in what we call an acute scenario or in something that's a persistent pain scenario. And it also, though, when you have that hypervigilant, threat-sensitive brain, it isn't just about pain. This affects basically everything. And so there's a reason, again, we see anxiety and depression and pain and other things together. But people also have a tendency to have more autoimmune conditions. People will have more gastrointestinal conditions, palpitations, and other things I'm not getting into. There's too much information. So this is not just about pain. It's understanding if these contributors here, no one's broken, but they're important enough that we need to start understanding how these things fit together so we can target them. And it's not just for pain. And again, I would be shocked if people don't start doing the Curable app. And if you're finding that good results are coming from it, if you're shocked and like, wow, how come I don't feel so much stress? Or how come my anxiety is going down? Or how come I seem to be requiring less medications, or my diabetes seems to be under better control, or my IBS seems to be doing better. It all makes sense, because once you start pulling away that heat and oxygen, this is not just about pain. And again, for pain specifically, though, it's when we see improvement in outcomes. So people will say, well, people with chronic pain can't get better, and that's not true. And I know you have your stories in your own community of people who have just done wondrous. I will tell you, in our community, which is, it's not a community, not a curable community, but we have our own pain community here. I have some local clinicians in my neck of the woods that we've been doing work for about 5 years. We don't talk about managing pain anymore. We talk about mastering pain, because we have people that had pain starting when they were 14. They're 74 years old now, and they don't describe themselves as being in pain every day. Now, do they experience pain? Absolutely. When she fell and she broke her ribs, she experienced pain. She also, though, used the skill sets that she was delivering or developing, that when she was lying on the ground waiting for someone to come pick her up, that she actually had minimal pain, she said, in that moment of time, despite having broken ribs. So these changes we see are when we move from a belief system that says pain equals damage, that pain equals structure, that every time we're experiencing pain, that body damage is occurring, into understanding that pain is constructed, or that pain has all these influencers that comes together in order to construct an experience of pain. Lo and behold, people tend to get better. As we move from an idea that there's nothing I can do, something must be done to me. Those are typically the surgeries, the injections, the medications, but we can even cut things like any sort of passive therapy that doesn't require engagement, that are done to you, that you don't have to participate in order for them to have their effects. That includes things like manipulation. That includes things like acupuncture. That includes things like herbal supplements in a lot of ways. The more we can move away from that passive-based modalities into active modalities, things like movement, mindfulness, meditation, expressive writing, cognitive behavioral therapies. I was just talking to somebody else today about biofeedback. These are all skills that you can learn and develop, and they require, though, engagement. You actually have to practice them in order for them to actually have an effect. As we move more towards that realm, people get better. Pain self-efficacy. What self-efficacy is confidence. It's the confidence that you may not have the outcome that you want, but you can start the process. So if it's like looking at the mountain and say, I don't know if I can reach the top of the mountain, but I'm confident I can start taking the steps. And the more confident people are in assuming that there are steps that they can do to help with their pain, and we increase this sense of self-efficacy, lo and behold, we see pain outcomes improve and pain diminish. And then the big one, or the lower one, is psychological distress. And psychological distress is referring specifically to threat-based stress, because stress in and of itself is not bad. We have challenge stress, which is actually good stress, and we have distress, which is threat-based stress. And the more we can develop effective stress mastery strategies, where we can start perceiving things not as threats, but as challenges. We can start chunking. We can start pulling in. We can identify where we can act and where we can't. We can identify who we need help from. We can ask for aid if we need it, and we don't feel we can't ask people for help anymore. As we decrease psychological distress, as we decrease that stress, lo and behold, you can start experiencing less pain and feel better, and people can get better. Now, and what's fascinating to me as the reformed interventionalist is when you look at all these other physical modalities, when people get better, again, remember I said people can have back fusion and get better. The improvement seems to be correlated with changes in pain beliefs, their self-efficacy, decreased distress. They're not changing associated with imaging. They're not whether or not the fusion was satisfactory or stable or not. They're not associated with increasing people's what we call passive coping. So not people think that they have to go in every month for an injection, or have to go in every month for whatever procedure that they don't control, or even muscle change. This was quite challenging for some physical therapists I work with, because when you look at exercise program for back pain, they work. But it doesn't seem to matter what type of exercise program that you do. And the people who got better, it didn't seem to be correlated with how strong the muscles got or how big those muscles got. Instead, if you get people moving again, they tend to feel more comfortable in their bodies. They feel more confident in their bodies. They feel they have more control of what they're doing, and there's less fear associated with it. So it was basically these central factors are what changed, and that was what was shown to be correlated with improvement when it came even to exercise. It wasn't the degree of muscle change; it was the changes in these cognitive and affective components. Now, the challenges with this, because there are certainly challenges, and I know you guys are aware of these. is while pain is created from three elements, and most of us focus on one. And I know you guys don't, because I know you guys talk a lot about emotion and meaning and past trauma and things like that. But the rest of the world doesn't. They seem to think of pain as either there's real pain, which means that there's damage, and then there's something else, which I don't know what. Uh, Somehow there's something else out there. So the focus, though, is on sensation. It's looking for quote unquote causes. It's looking for pain generators. It's looking for structural factors that somehow the pain pus is oozing from. That's where the drugs are supposed to be targeting. That's where the injections, that's where the surgeries are all focused on. This is a multi-$100 billion industry. But the fact of the matter is, when it comes to pain that has lasted, pain when we have all this heat and oxygen here, medical treatment is limited. Now, this is very frustrating when I talk to physicians, because many of them want to help people, but the tools that we have, the cutting, poking, looking, and drugging, aren't effective. But drugs are fast. It's easier when you have limited time in that environment to simply write a prescription rather than try to educate and talk about things with your patient and find what else is involved in contributing to that experience of pain. And it would be blatantly wrong of me to not say flat out surgery injections are profitable. And if anybody here doesn't think that makes a difference on why some things are done and when some things are not, let me tell you, what's that thing about, I got some land to sell you in Florida, because this has been demonstrated over and over and over again, that if you are paid to do something, you will default to doing it over not doing it if the situation is somewhat equivocal for you. And this happens over and over and again. And again, speaking as a reformed injectionist, I will tell you, this is a huge hurdle to overcome. It was extraordinarily difficult to do when you're being paid to do something, to stop doing it. And then lastly is misinformation, fear, and false beliefs. And the importance here is you will be bathed in the media by a bunch of bad information. I get Google alerts on back pain and pain and other things that are involved with pain every week. I used to do it every day, but it drove me crazy and became too stressful for me. That there's so much bad information up there when it comes to pain. You have to be very careful and choosy on who you listen to, what you listen to, and what they're saying. If there are things that sound like it's a device, a magic device, anything that's sort of external to your personal control, I would be very hesitant, and I would certainly be skeptical. I'm not saying don't listen. I'm not saying don't investigate it, but be very skeptical, because there is a lot of bad information out there. And there's certainly a lot of people stoking fears and false beliefs about pain. And if you're not walking the right way, you're going to be riddled with pain the rest of your life. Or if you don't have the right shoes or right mattress, all this other stuff, there's a lot of bad information out there. So where would I recommend start is, if you're struggling with pain, one of the first things I would start with is questioning our own belief systems. And again, it's not changing your beliefs, it's being willing to question them. I've seen people who are like, you're saying stress is all my pain's all in my head and it's all about stress, but my pain has nothing to do with stress. But then when you actually talk to the person, their life is absolute chaos and there's stress everywhere out there. And so the thing to do is just take a moment and pause and step back and be willing to say, well, instead of saying this isn't about stress, or it isn't about this, or isn't about past trauma or anything else, is to say, well, what if it was? What would change? What if it was? If this was somebody else, what would I recommend to that person to do in this scenario? So we can at least start questioning these belief patterns and start questioning what we believe to be true about pain. I'm a huge proponent on understanding pain. I have a tendency to talk more about pain than most people I know, like actually the science of pain and in-depth details. This is not for everybody, but I do think that some basic idea of understanding key pain concepts, such as what we talked about tonight, that's one of the reasons I want to do this presentation, that the more we know that pain isn't about damage. Now, I'm not saying you ever ignore it, but what you're basically looking at is, if you're experiencing pain, is you be able to see threats in multi-dimensions. So yes, there's a physical threat. If you stumble and you hit something, is the leg broken? Is it cut? Is there something there? But if you're only thinking in terms of body and nothing else, then you're going to ignore the threats like abusive relationships, or the financial stressors, or parent-child relationships, or workplace environment. All these other potential threats become ones that are you can visualize and see and at least be able to incorporate, but you have to be aware that they actually contribute to constructing experience of pain. And all of this then coming down to being able to think differently, because the more we can start thinking differently about pain, the more we can start seeing pain transformation, which is where all the fun stuff is, and how people are getting better and rebuilding lives and developing communities like this one where you're supporting each other and knowing that there's so much more out there than feeling like trapped, that you have to be in pain and there's nothing that you can do. And people are telling you can only manage it. And this is the best it's ever going to be. Because I'm telling you, if you're a human and you have brain and a body that are built to survive and to be resilient and to heal, in some situations we just start approaching things a little bit differently and lives can be transformed, which is super, super exciting to me. So with that, just to recognize that the purpose of pain is protection, not punishment, that to understand pain is constructed. I know that's probably one of the more difficult concepts there, is to start thinking in 3 dimensions, not just one. But when we start seeing all how these constructed elements fit together, we can start targeting treatments with intention, awareness, and intention, and that's where things become super, super fun. And with that, I don't know what our time is, and I'm going to ask Sarah here. That is my presentation. I have nothing else for me, but I'm happy to take some questions if we have any. Again, I have no idea what's going on in the community because I can't see this. Or feel free to email me at drkevin@straightshothealth.com if you have any questions or comments. So Sarah, what do we do next? Are you still there? Oh, wait a second. There's some questions apparently. I see some questions in the comment back. So here's one. Okay, makes sense, but how does protection pain explain autoimmune disease? All right, so here's the key thing for autoimmune disease, right? Is if we're not thinking causes anymore, but we're thinking contributors. When you have an autoimmune disease, what is an autoimmune disease? It is when the body starts to basically become overprotectivized and it starts to attack body tissues because it doesn't understand that they're actually normal body tissues, right? So when you have an autoimmune condition, and you have an acute flare of that autoimmune condition. What I mean by that is then you have antibodies that are actually attacking your nervous tissues, and you'll get things like swollen joints, so rheumatoid arthritis being a big one, ankylosing spondylitis being another one. You'll have these acute flares. Now, that swelling, red hot, and inflamed tissue, again, that is not pain. But what that is that is a lot of sensation, and it's really easy to burn fuel. So in that scenario, now we have lots of sensation. We still have to have that attention. We still have that meaning to it. And that'll change a little bit. If you're like saying, oh my God, my rheumatoid is flaring again. This is the worst thing in the world. This is horrible. This is awful. What you're doing is you're stacking a bunch of oxygen into that pain fire. So now you have a lot of easy to burn fuel because you have an acute pain. You can have an acute autoimmune flare. And then we're putting on the oxygen because we're putting a bunch of fear and then we're putting a lot of heat in it because you have a lot of anxiety there, and it gets worse. Now, the other part to consider is this, though. When we're looking at autoimmune disease, our stress response plays a key role. When we're looking at pain, our stress response plays a key role. So the more that we can learn stress strategies, not only can that impact pain, but that can actually impact autoimmune disease. Because as we see, if we decrease sort of this threatened, highly sensitive nervous system. So now the body, you can kind of imagine your entire body is on high alert looking for dangerous things. Part of that response is your immune system. And so when you have a highly stressed, particularly chronically stressed immune system, it tends to start attacking things it shouldn't be attacking. There's many different reasons for it, but they go hand in hand. So if you have autoimmune disease and pain, the same skill sets that you can learn for pain, you can apply them with awareness and attention to autoimmune disease as well. And I'm not saying come off of your rheumatologic agents if you have rheumatoid or your biologics or anything like that, but learning these same strategies, learning these active-based therapies, taking active control can actually help both conditions. All right, here's another question was, how does neuropathic pain fit in this picture? I know the pain can't harm me. I still have the sensation though. So this is another interesting one to me, because when we're looking at neuropathic pain, right? So diabetes, you have diabetic peripheral neuropathy, and we have diabetic peripheral neuropathic pain. Diabetic peripheral neuropathy is when we have objective signs that the nerves themselves have had some damage. And this occurs, what we think is because you have too high blood glucose and it starts poisoning the small fibers, and that typically starts in the feet and hands and things like that. That sensation that is there, it tends to be either a numbness or coldness, stocking glove sensation. So what's then the difference between diabetic neuropathy, where we have that sensation, and we have diabetic neuropathic pain, the sensation's the same, but that attention and that emotion then has changed a little bit, where people are starting to pay more attention to that sensation and starting seeing a threat associated with it, where they're saying, oh my God, my pain is, or my diabetes must be acting up again. My hands feel so numb now. Well, now we're paying a lot more threat appraisal to it. And we also have that meaning of, this means my diabetes is worse. And we start thinking about all the fears of the future, or all the fears that we have about what this is going to mean to me, right? The more we can pull away the threat, and the more we can take away that emotionally laden meaning to that sensation, or means horrible things about my diabetes, and kind of pull that away, the less the sensation means anything. Because if you have a sensation that really that you're not paying attention to, actually the sensation doesn't exist. If you have a sensation that has no harmful meaning to it, it becomes negligible. And I hope that makes sense, because that one comes up over and over and over again, and I'm trying to explain it better ways, but sometimes my words fail me. Okay, I believe I overdid at the gym. Noticed sensation in the back. I decided not to do anything. No heat or oxygen, so I kept going. A week later, I couldn't sit, drive, or work. I'm so surprised, frustrated, confused. I feel like I have approached it in the way described here and end up having a huge amount of pain. Okay, so if I'm going to assume there's two things I would assume here, and assuming making those ass of you and me and all that stuff. If you have not ever been in a gym, or you've not been in a gym in a long period of time, and then you aggressively go back, in that scenario, your body is not used to it. And so what you're going to see is there's going to be a lot of tissue information going up to the brain. And this seems to happen more and more frequently the older that we get. In fact, for me, it started happening after the age of 35. What I noticed is I was sorer easier, quicker, if I wasn't consistent with my exercise. Now, again, that soreness per se, those sensations coming back are not pain, they're just sensation. And so when we have that sense, so I've been tremendously sore, so much so that I can't even move my arms sometimes. But I wouldn't consider that pain, because I don't have any fear associated with it. Now, for this particular scenario, and again, I'm not giving any sort of medical advice here in any way, shape, or form. But I would look at those other variables as well. So if we went out and we exercise too much, we're going to have a lot of sensation. We're going to have a lot of information coming from the brain. But if there's any sort of fear, or any sort of frustration or confusion or uncertainty there, that frustration, confusion, and uncertainty of thinking, oh my God, what is this? Why is this happening to me? All these why, what I almost call them a why me question of why is this occurring? That tends to seem to increase that, provide a lot of oxygen to that pain fire. And so I hope that sort of makes more sense. It makes sense to me, though, if you start something, you're like, oh, how come this isn't working? I just did it, and I tried to ignore it, but then the sensation kept persisting and it got worse. When you have that sensation, it becomes really, really easy to start building fires from it. And frustration, confusion, anger is another big one, which we haven't had a chance to talk to it. There's a lot of anger associated with pain. Anger provides a lot of oxygen to a pain fire. All right. Are there any neuroscience research findings that show brain regions or networks are disrupted in chronic pain patients? fMRI. So, and there's two questions in here. Yes, no, the brain changes. So the brain tends to process information differently. I don't look at those as specific to pain per se. And what I mean by that, there was a couple studies that came out and they were talking about, whoa, there's physical pain and emotional pain, and they light up different areas. But the area, what seems to be involved when we're thinking about increased experiences of pain, is a specific network that's called the salience network, and is not specific to pain. What the salience network does is it looks for things that are important to you, salient information. And when people have had even persistent pain for some time, if they have past histories of trauma, that salience network seems to get engaged sooner and become more overactive than people who don't have those same changes. So rather than think about them as pain specific, I look at them as changes in how the brain perceives threat. And the brains then have changed over time to see threat easier. Now, one other thing with that, though, is just because we can see something, it doesn't mean that changes what we do for it. And so just because those changes have been there, you have changes in the salience network, or changes in how your brain processes information, or even having a stroke in the past, What we used to believe about 30 years ago is what you were, you had a certain number of neurons and the brain was the brain. That was all that happened. Any sort of brain damage or if the brain changed, there was nothing you can do about that. Now we know that brains are amazingly neuroplastic, which means they can change and develop. You can almost view them as a muscle. And so if you've built up a threat sensitivity muscle over lots of time, because a lot of trauma and you're seeing threat and you're seeing danger, you can start de-escalating that threat muscle by not working definitely to start de-threatening your environment, de-threatening the way you perceive things, and you can start developing your safety network. So you can start doing things like, again, the writing exercises, gratitude exercises, humor is a big one. We're start building up that alternative neuro pathways. Let's see. How can the pain from nerve entrapment be successfully alleviated without surgery or medication? So when we're talking about nerve entrapment, that generally what tends to be, people are talking about, the pain is coming from a nerve that's entrapped. Now, if that was true though, then every nerve that was, oops, what happened here? Then every nerve, sorry about that, I don't know what I just did, that every nerve that was entrapped, every person who had a nerve that was entrapped would actually have pain. And what we know is that doesn't happen. So what I would say is always look at, if you have an entrapped nerve, that entrapped nerve may or may not be related to the pain. But if it is, all that is this potential fuel source, I would still be looking at the heat and the oxygen supplied to that pain fire. Because again, this is not just about acute or chronic. If you had your leg stuck in a rock somewhere, and you had that leg being crushed by that rock, that would be a lot of sensation right there. But in that moment in time, anything that you can do to start feeling safe, and anything that we can decrease this sense of helplessness would be of benefit. Now, you probably still hurt, obviously, but we can improve that just by working on the heat and oxygen. And again, for a long period of time, the longer that pain has been there, the less there is this, what we would call a primary peripheral nociceptive contributor. That actually seems to change to either go up to the brain or the spinal cord, so more of a central nervous system thing. And that is much more of what we would call these heat and oxygen-based therapies become key. Can you talk about trigger points and if this is a real thing? All right, so trigger points. Trigger points are an interesting thing. So what trigger points are supposed to be is basically like a microspasm within the muscle themselves. You can sort of palpate them. You can kind of feel a local contraction, like there's a little knot, right? But we have knots everywhere. Now, what's interesting about trigger points is they're very difficult to get interclinical. Having two people examine the same person, they often won't find the same trigger point. All right. That doesn't mean that again, that perception, that tightness isn't there. It just means the actual physical finding becomes very, very difficult to duplicate, and somebody else may feel a knot somewhere else in their body. But then we start looking at treatment for trigger points. And what's interesting about trigger points is it doesn't matter really what you're doing to them. And what I mean is, you can put a needle and you can put steroid in. Not recommended, but you can do that. You can put a needle into them, and then you can put local anesthetic. You can put a needle into them, you can inject saline. You can put a needle in them and not inject anything. You don't even have to put a needle on them. You can just push them with a finger, and you get the same reports of relief from them. In fact, that's what it seems to be stored over and over again in literature. So for me particularly, I don't look at causes. So trigger points to me just say that someone is under distress. But would I actually target those trigger points with a passive modality? Like, would I tell people to come into my office, I'm going to do trigger points on them? No, I wouldn't do it. Because I would want to do something or encourage my person that I'm working with. What can they do to take control of that scenario? What can they do to relax the muscle? What can they do to feel less stress? What can they do for themselves that they have control over, rather than trying to tie them to, well, you need, every time you experience this, come in and get a trigger point injection. How does tinnitus, not pain, but sensation fit into this? Tinnitus is actually very similar. I actually have tinnitus, and it's the same thing. If you kind of think about, for me particularly, it's a high pitched whine, and the more I focus on that sensation, that bzz, the more I notice it. The more I worry about that sensation, the larger and more prominent it gets. So I try to do this thing where, one, I recognize that it's tinnitus and I'm going to be okay. So I don't put a lot of attention on it, and I try to see it in a non-threat based way. I try to see it in the most neutral framework as possible, that this is it's not a big deal. I'm going to be okay. The other thing that is really, really difficult to do is to direct my attention elsewhere and pay attention to other things. Now, this is very, very different than what we call is try not to stop thinking about it. Okay. When we say, don't think about this, that's thought suppression. That's in the old, the example of people is don't think about white bears. What tends to happen if you tell someone not to think about white bears, they might not think about it in the short term, but man, white bears are going to rebound. You actually have this rebound thoughts associated with it. So I'm not saying I'm not going to hear the sensation. What I basically try to do is move my sensation somewhere else. So again, that's not paying attention. It's directing my attention somewhere else. So I'm not getting in that suppressive effect where I have to worry about rebound or anything like that. But it's very relevant in the same way. The more stress that you experience, the more you tend to have these weird sensations pop up. The more you attend to those weird sensations and to feel threatened by them, the more we give prominence to them and they start to rise and get stronger. And so what I do, again, is I try to not pay or see them threateningly. I try to notice them now. This is almost going to sound like mindfulness, because you got to notice them in a non-judgmental method. The sensation is just a sensation, and then I try to let it pass. And hopefully that answers that. And I think that is all those questions there. And we have been on for, wow, almost 2 hours. So again, if you guys hopefully found some value out of this, if you have any questions, feel free to email me at drkevin@straightshot.health.com. I really appreciate you. I really appreciate the Curable community. This is one of the reasons I talked to John about this, is you guys are doing amazing things. And it's not just the app, it's the fact that you're supporting each other. We need people to support each other. We need communities where people can feel safe, where people feel valid, that they know that their pain is 100% real and it's 100% severe, but there are things that they can do for it. That's where the excitement comes. Again, one of the things that we found locally is the more that our community gets stronger, the more it spreads, the more people, it's just wonderful. And so it's wonderful to see that you guys have an online community where you're supporting each other, that you're learning tools, that you are, being really active and engaged in pursuing things that you can do for yourself. So it's very exciting to me, and it's a privilege to be here tonight with you guys. And with that, I think I am going to say goodbye. And until next time, everybody, stay well.